Good morning, everyone. Now, as you see in this picture, this child has multiple teeth which are carious and they are grossly decayed. A normal restoration cannot suffice. When a child is having such a bad teeth, he will have a poor quality of life. Why? Because this will lead to sensitivity to cold and hot stimuli, so because of which it is difficult to brush, and this will lead to worsening of dental problem. So since because of this sensitivity, patient may prefer for poor preference for soft food, either he doesn't eat any food, so this will lead to poor general health. So, because of which there is frequent occurrence of cold, cough, and fever, leading to loss of weight and poor quality of life. So, when we restore the tooth, he will be able to masticate the food properly, and also speech will be fine. So, that becomes the importance of placing a crown onto the tooth. This improves the quality of life. So, today I'll be covering a chapter on crowns in pediatric dentistry. Stainless steel crowns in pediatric dentistry were introduced by Dr. William Humphrey in 1950. Stainless steel preformed crowns are prefabricated crowns, that is, they are ready made crowns which can be adapted to the individual primary molars and cemented in place to provide a definitive restoration. They are superior to large multi-surface amalgam restoration with longer clinical lifespan. Coming to the classification of preformed metal crown, they are based on the morphology: untrimmed or uncontoured crown, pre-trimmed crowns, and pre-contoured crowns. As the name indicates, the first one, they are neither trimmed, neither crowned, neither contoured. The second one, they are not, they are just trimmed and not contoured, and the third one are just pre-contoured. They are just contoured. Then, based on the composition, they are classified as stainless steel crowns and nickel-based crowns. So, and now this is the availability of SS crowns by a 3M company. And when do you want to give an SS crown to the patient? When extensive decay in primary teeth, after endodontic therapy, as a preventive restoration, you can give SS crowns. For the teeth with developmental defects and anomalies, as an abutment for a space maintainer or denture, temporary restoration of a fractured incisors. In severe cases of bruxism, the SS crowns are preferred. To correct single tooth crossbite, SS crowns can be given. Interim restoration until a permanent restoration can be done. But when to not to give SS crowns to the patient, when aesthetic is of concern, when teeth that are near exfoliation, if the tooth is about to fall, there is no need to give an SS crown. And if patient is having allergy to any components of SS crown, then you are not supposed to give a SS crown. What are the advantages and disadvantages of SS crowns? Advantages are they are more superior to multi-surface amalgam restorations. They are acceptable, cost-effective, and saving. Disadvantages are poor aesthetics. Now, what are the armamentarium we require for SS crown restorations? Are burrs and stones. They are flame-shaped, tapered Fisher burr, finishing burr, greenstone burr, rubber wheels, pliers, Johnson's pliers, crimping pliers, straight hook pliers, etc. Followed by crown and bridge scissors, crown seaters and removers, sharp scalers or instruments, luting cement, glass glass, spatula, floss, articulating paper, wax sheet, glass marking pencil. Now, these are the flame shaped burr and a needle thin burr, greenstone burr, and rubber polishing burr. And factor to be considered in preoperative evaluation of the patient for excess crown restoration, dental age of the patient has to be considered. If the tooth is near to exfoliating, there is no necessity of giving excess crown. And then cooperation of the patient is must, motivation of the parents is must, and medically compromised or disabled because they will not be able to maintain their oral hygiene. So SS crowns should be given. Then coming to the clinical procedure, for the first step, that is preliminary step. Here we need to evaluate the preoperative occlusion, then give a local anesthesia and remove the decay. Coming to the selection of crown. Now, how do you select the crown? There are two methods. One is trial and error method. You select one crown. If it is bigger, go for the smaller one. If that is small, still bigger, then go for the smaller. one. This is the trial and error method. And the second method is measuring the mesodistal width of the crown and measuring the mesodistal of the tooth structure and measuring with the available crown. So two methods, one is trial and error method and second one is mesodistal measurement. Now coming to the tooth preparation as first one is occlusal reduction. So this has to be done 1 to 1.5 mm, followed by proximal reduction. The amount of proximal reduction should be as such that a probe should be able to pass through it, and then followed by finishing. Evaluation of tooth preparation includes occlusal clearance, proximal contour, ledge formation should not be there, feather edge preparation should be there, buccal and lingual curves will not may be necessary, and point angles and line angles should be rounded off. Crown adaptation, the initial seating of the crown. So when we are seating the crown for the mandibular, it should be seated from lingual to buccal side. But when you are seating from for maxillary, it should be seated from buccal to lingual side. This is because of the anatomy. Buccal bulge is present in the maxillary. That's why we prefer the opposite. Coming to the spreading adaptation principle, so when you are placing an SS crown onto the tooth, make sure that only 1 mm of SS crown is present within the gingival sulcus. Now, how to make sure that only 1 mm of 1 mm of stainless steel is present below the gingival margin? So, place an SS crown, then along the margin of gingiva, mark with the help of a marker or with the help of a scaler, scrape with a scaler. So, once then remove the crown, then make sure that you leave 1 mm of crown below this marking and cut off the X-ray. This makes sure that only 1 mm of crown is present below the marginal gingiva. Now coming to the crown preparation, so as I said before, you can use a rubber greenstone burr, or you can use a band scissors, stainless steel scissors to do the cutting. And crown contouring can be done with the help of a contouring plier, that is Johnson's plier, which is done at the middle one third of the crown to produce a billing effect. Now coming to the crown crimping, this is crown crimping is done with the help of a crimping plier, which is done at cervical one third of the crown to have a tight marginal fit. Now after fitting the crown, check the final adaptation of the crown, then do the finishing and polishing of the crown. Cementation of the crown can be done by loading Asanoma cement, and excess can be removed after placing with the help of a Pro Explorer, and also from the proximal side it can be removed with the help of a floss. Now coming to the modifications of SS crowns, this was given by Nash, the quadrant dentistry. So whenever you have a two adjacent tooth which has to go for SS crown, first finish the preparation of one tooth and then go for the other. But if you simultaneously do the crown preparation of both together, then you will not have any reference for crown cutting. You may end up in excess crown cutting. Then, if a SS crown has to be placed adjacent to class 2 amalgam, then how to proceed? First, you have to do a tooth preparation and also carry on with the class 2 cavity preparation. Then, cement the crown. After cementing the crown, place a matrix band along with that wedging and do a amalgam restoration. What about in cases of space loss? In the case of space loss, you need to do more than the usual reduction of proximal area. Now coming to the other set of modification which was given by Mink and Hill, if you have a larger crown for a smaller teeth, how to adjust the larger crown? What you can do is you need to give a slit on the buccal side, then overlap the slits and then weld it and do polishing and place the crown. Now, what if you have a smaller crown for a large tooth? It's not fitting. So you need to give a V-shape slit, a V-shape cut, expand that V-shape, and the exposed area of the tooth can be patched with the band material. So this is how it is done, and the welding has to be done. Now, what if you have deep proximal lesions like this? So excess crown will be covering to some extent only. For deeper proximal lesions, you need to attach or weld a band material. What about open contact? So open contact will usually cause food packing, increase plaque retention, and subsequent gingivitis. So select a larger crown or exaggerated interproximal contour to establish a close contact. Interproximal contour can also be built by addition of solder. Other set of modification includes if stainless steel crowns are available from anterior tip, okay, fix the SS crowns for the anterior tip, followed by removal of the crown, stainless steel crown on the labial aspect with the help of a burr to a composite restoration. Then we have for SS crown, as I said in the indications of SS crowns, SS crowns can also be used for the correction of a crossbite. That is, single tooth crossbite correction can be done with SS crown. A reverse SS crown is placed on the maxillary tooth, the lingual side on the opposite side, on the labial side, and the labial portion of the crown is placed on the palatal side. So this will help in the correction, and this has to be placed for 1 to 2 weeks. Coming to the complications of SS crown restoration, there could be an interproximal ledge formation. So, because of which the crown gets stuck, so it has to be corrected. Other complications include crown tilt because of the loss of lingual margin of the tooth, poor margins, or there could be inhalation or ingestion or a nickel allergy. SS crowns can also be given for permanent molar indication, extensive caries, interim restoration, endodontic outcome uncertain, traumatically fractured posterior teeth, and developmental malformation. Crowns for primary anterior teeth. Objectives of giving crown for primary anterior teeth is because we have to restore the aesthetics, preventing psychological trauma, restoring the function, and preventing the fractures. Indication multi-surface caries, incisal edge involved. If incisal edges are involved, high risk patients, extensive cervical decay, and pulp therapy in cases of pulp therapy. So anterior stainless steel, anterior for crowns for anterior teeth, anterior stainless steel crown can begin, which I initially explained. It is also called as facial cut out stainless steel crowns. Then you have pre-veneered SS crown. This SS crowns will look unaesthetic, so that's why pre-veneered SS crowns were introduced, where composite material thermoplastic resins have been bonded onto the SS crowns. They have been bonded mechanically or chemically. Advantages are aesthetic, retention, convenient, durable, reliable. Disadvantages contouring and crimping, because of which the composite or thermoplastic resin may fracture. It can be expensive and cannot be heat sterilized. Commercially available vineyard crowns are gem crown, dura crown, kinder crowns, pedo pulse. This is how it looks. Crowns. And then you have dura crowns, kinder crowns, and pedo pulse. And there is something called new smile primary crowns. Now there is something called as polycarbonate crown. They are easy to trim, good anatomy form, aesthetics in a wide range of sizes for sizes, canines and premolars. Universal, it has got universal shade, smooth surface finish, and it is aesthetic than SS crowns, extremely stable dimensionally and unaffected by acids, either an alcohol. They lack strength, they do not resist strong abrasive forces, hence they may fracture during the masticatory function. They have poor abrasion resistance and not indicated in bruxism type deep bite. Polycarbonate crown, how they are placed. The crown is selected according to the mesodistal width and the cervicoincisal length of the tooth, and reduction is done labialingually 0.5 mm and contacts are removed by reduction mesodistally. 1 to 2 mm of incisal reduction is done, and crown is selectively ground at stygial aspect, and crown is lined with acrylic or composite material for better fit, and the margins are trimmed and finished, and then crown is cemented with coating agent. Now coming to the pedo strip crowns. These are the crown forms which are filled with composite and bonded onto tooth surface, and the crown form is removed. Coming to the technique of pedo strip crowns is again doing the crown cutting and selecting the strip crown. After you select the strip crown, you need to create a hole in the incisal aspect so that the excess of the composite material can flow out. And once the composite has been placed, place the crown onto the tooth structure and cure. So once curing is done, now you can strip off the plastic, that is strip crown, which is placed onto the tooth structure, and do the finishing and polishing procedure. Thank you for patient listening.